everyone, and welcome to another exciting episode of MedSynapse podcast. I'm your host Hetvi, and today we are turning our focus to a pressing issue in pediatric health that impacts countless children across the globe, which is asthma. According to World Health Organization, asthma is one of the most common chronic diseases in children, affecting an estimated 235 million people globally. In India alone, a recent survey indicates that around 10% of children suffers from asthma, making it a crucial topic for healthcare providers and parents as well. Joining us today to guide us through today's topic, which is managing asthma in children, is a leading expert in the field. She is not just a renowned pediatrician, but also the current president of Vellore India of Indian Medical Association, Dr. Narmada Ashok, with a wealth of knowledge and over a decade of experience, particularly in pediatric asthma care. We are pleased to have her back gracing our podcast with her insight. So, Dr. Narmada, welcome back to MedSynapse podcast.
Such a pleasure joining you on this platform on a topic which is very close to my heart and which really, as you said, needs a very important intervention and public awareness on the same.
Right. So let's start our conversation by addressing the basics. What are the initial symptoms of asthma in infants and children that are often overlooked or neglected by parents and healthcare professionals?
First, let us think about what are the very common symptoms. That is very quite because here in asthma, the parents do not tend to ignore, but what happens is it really overlaps with many of the symptoms that occur in that age group. So I will just go, as you rightly pointed out, asthma, you have the infancy stage, you have up to 5 years and then above 6 to 9 years of age. Even if you can see that all the guidelines clearly differentiates it. Why? Because less than 5 years, it is very difficult to tell that they have asthma. We have a lot of diseases. By about 6 to 10 years, we do have some objective evidence to talk about to clearly define the diagnosis. And in infancy, which you rightly said, again, we don't name it as asthma at infancy because we do have certain other factors. And if a child is going to have asthma symptoms by about 6 months, then we'll always think first about alternate diagnosis and then come to asthma. Having said that, what are the very common symptoms is one is the coughing. And as you all know, wheezing is one thing which clearly defines asthma. The most thing is a difficulty in breathing or the shortness of breath. And there is a limitation in the activities. So I'll define each of them because it differs for each age group. Cough is a very common symptom that comes up in the infancy and the less than 5 years. The cough is predominantly in the night time. And what happens is the child sleeps and then it coughs and then it has a vomit. It's called as a post-acid vomiting after the cough, and then it goes up to sleep. So this is very common and it can also happen in other viral infections. But what we see in asthma, it is usually the child starts sleeping peacefully and then it has that. In an older age group of 6 to 10 years, the same cough will be precipitated by some playing episodes, or the child might have, the child will sleep immediate in the night and immediately get up with cough. That is evidence that it also has sinusitis. So they will have some mucosa coming into the throat and then it will cough. But asthma symptoms are more in the middle of the night when the child wakes up. This is a very, very disturbing symptom. So we have to clearly define. And even in the younger age group, we will see that the cough comes out whenever the child is actually playing or laughing. The child will be playing. It will not disturb him. He will be playing with his friends and suddenly he'll start having the cough completely. And one more thing, in the infancy stage, what happens is it is not coming up like these children will have some sort of a wet cough, continuous wet cough. At that time, we will be thinking we will think about alternate diagnosis because whatever the cough symptoms I have spoken for the older age group in asthma specifically, it's a dry cough. You don't get a mucus production. So if there is something like, you feel that when a child is coughing, that there is a lot of cold in the chest, then you will have to think about alternate diagnosis, especially in a younger age group and less than 9 months of age. Having said that, what is the next thing is the wheezing episodes. What thing is that what is perceived by the parents and what we listen. Sometimes, when there is a nasal block during cold, the mother will say that there is a noisy breathing. That is very different. That when we use our stethoscope, we will often hear the wheezing sound. And the mother also, when she puts the ears onto the chest, she can hear the wheezing episode, and it will be more prominent in the night times. The other thing is difficulty in breathing. Child cannot breathe as I said, any sort of an exertion. As in a younger age group, even a laughing or running about itself is an exertion, even in between the home itself. So they will not be playing. And the other thing is a reduced activity. This is a very, very important one in this scenario, because nowadays children are so used to mobile. You give the mobile, they sit and play. They go to a mall. The children who have asthma will have difficulty in walking. So who are uncontrolled. I mean, people are treated, it's fine. Those who are what they will prefer is they will ask you to give the mobile and they will sit simply. So the mother will say whether there is any reduction in activity or a limitation. She will say, no, everything is normal only. You will have to specifically ask whether he prefers to sit rather than to run. Then that will clearly tell us what's the thing. So these four are we call it as a salient feature. And then we have to sit across to them. Usually we don't make the diagnosis in the first time itself. It has to be recurrent also. So we talk to the parents. We clearly find out what symptoms they belong to.
Yeah, these symptoms are often overlooked because sometimes they're very common.
True.
Moving on to the diagnosis, can you describe the key diagnostic tests used to identify asthma in children? Do these tests differ from those used in adults?
Yes, 2-3 things. See, children, what mainly asthma is a reversible airway obstruction. It is reversible. That's the one point we all have to take into consideration. So, like whenever we give medicine, it can come back to the normal state. So, whenever the test which is being done, it can show. We don't do the test at a time. We first initially give one test, which is called as a pulmonary function test. So, these are all airflow dependent tests, and it's very it's a dynamic test. You don't do it like an X-ray or a CT. X-ray and CT can never tell asthma diagnosis. They always tell us about only a lung infection. So asthma, when we make a diagnosis, it's a dynamic test. We ask the child to blow into a machine, and then we give the medicine for the asthma. Then we see whether there is a variation, there is an improvement in the way they blow. Basically, asthma comes during expiration. That is, it is a lung capacity the child is able to blow. So this, as you know, cannot be done by a child who is less than 5 years. He cannot blow, he cannot sit in a place. It's very difficult. It's actually very difficult even for 6 to 10 years of age group. But some children are very intelligent, so they do it. But less than 5 years, most of them cannot do it. But now only we are trying to get into certain new advances like impulse oscillometry that can be done when in a normal breathing. So more than 6 years, now the guidelines clearly say that we need to have a diagnostic criteria, and that is based on the pulmonary function test, for which we use spirometry and something called as a peak flow meter. Peak flow meter is something like a glucometer. When we see the sugar value in your home, we ask the child to blow into a very small machine and record the value for about 2 weeks, and then we ask the parents to bring the thing. Whereas in a spirometry, it's a more controlled one, and we do it in the hospital, and it is a little pretty long procedure. So this has been done in 6 to 10 years of age group, and this is almost similar to that of the adult age. So in adult, we have a little with the guideline, the values are different, the criteria might be a little different, but the machines and the criteria essentially the same. Coming to less than 5 years, we do not have, as of now, impulse oscillometry is coming up. We also have fractional excretion of nitric oxide, is FeNO we call. That's one more test that is coming up that tells about, the inflammation, or what is asthma is basically a process that produces inflammation in your airway. Okay, inflammation is something like I think you understand inflammation. It's like an immunological mechanisms that is occurring. So that will help us to diagnose. So that way we could use it in the younger age group, but predominantly less than 5 years. That is why I took my time in explaining the symptoms, where we rely more on symptoms and history of the parents rather than that we do not take the objective evidence of this. And so we will give leverage for revising our diagnosis whenever when the child doesn't respond to the regular asthma medication. We ask the parents to come back at 15 days and 1 month, and we ask all these symptoms. Is there any nighttime awakenings? Is his cough come down in the mornings? And if he's fine with that, then we know that he's responding to the medication. Then we clearly say it's an asthma. But more than 5 years, we have the test which has to be done, and that's almost similar to that of the adults.
Yes, thank you for clarifying that. Now, speaking of variations, what comorbid conditions are commonly associated with pediatric asthma, and how should they be managed concurrently?
Yeah, see, the comorbid is something like which it is closely associated with asthma. So they may come in together. The pathomechanisms can be the same, or they may be an independent mechanism also. So the most common comorbid feature we get is an allergic rhinitis, that is nasal sneezing and running nose. So the running nose is a very common accompaniment that parents have so much got used to it. So they don't, they don't tell us. So we have to ask: is the child getting up in the morning and starts sneezing? Is he having running nose throughout the day? Then they never connect. They think that this is different and that is different. So then that's called as an allergic rhinitis. And the study which I have done, which I have seen about 400 children, and 99% of them had allergic rhinitis. And this statistics is almost similar. There has been studies done in North as well as in South, which have shown that the incidence of allergic rhinitis along with asthma is definitely more than 75 to 80%. So that is very, very important. The other thing they have is the itching in the nose, which they have, as well as in the eye. So this is called as an allergic conjunctivitis. A child who gets up in the morning, continuously sneezes, and he'll be rubbing the eyes, and you can see dark circles that is coming up. So this is one more important thing that we have to ask, because the parents will not tell you, because they think that they have to go to an ophthalmologist and they don't see the connection between the same. And the third is obstructive sleep apnea. That is a child snoring or having noisy breathing in while he sleeps. So this is called as this is due to adenotonsils. Tonsils that comes in the back. It's very common in the children. That can also be one of the very important comorbid feature. And we call it as obstructive sleep apnea, when the child has so much of disturbance in the sleep that he snores, and then he has some apneic episodes. What happens is mother will think that he's snoring. We in India think whenever a person is snoring, it's a very deep sleep. In fact, it is not so. It's not a deep sleep. People who have a snoring have a difficulty in breathing. The airway is disturbed. They get up from the sleeping due to apnea. So then what happens is this child who has a nighttime snoring will get up in the morning. They will have a daytime somnolence. That is, they'll be sleeping in the school. So the teachers will think that he's a lazy and he's not doing his work properly, whereas this poor child will have this obstruction and he's got this allergic rhinitis and he will also have wheezing, and it's all connected to the same. Then the last and very important one is the gastroesophageal reflex, and you have the reflex of the acidity in the stomach. So this can come where the food can be a precipitator both for asthma as well as for gastroesophageal, or it can be an independent phenomenon also. Quite often due to the fast foods, due to the erratic food habits and all that, as well as basically younger children have more of gastroesophageal reflex. So whenever they have gastroesophageal reflex, the acid gets into the airways and they have the wheezing attacks. So we have to control. So this can be brought out only by a very careful history and a doc. And I would always say allergy is a multi-system manifestation. Asthma is a multi-system. You cannot be taking it as an individual disease. You will have to look into all these features, because the parents unfortunately are not aware that these are comorbid features. They will not tell you. They will go to the ENT separately. They will go to the eye specialist separately, and they would come to you. So you as a doctor or the healthcare provider is the one who has to ask these questions about.
Yes, that is very important to consider. Now, moving on, as we all know that COVID-19 pandemic has impacted many aspects of healthcare. Can you tell us how has COVID-19 pandemic affected the management of asthma in children, and what lessons have been learned during this period?
Right. So the COVID-19 pandemic the symptoms were so overlapping, and children. So one thing, we thought that the children were protected. Yes, they were protected. They were inside the home. They had less of a viral infections. And to be very frank, less than 5 years, the viral infections are a very, very important trigger. So flu infections, as well as whenever they go to school, you can see the child will start with an episode of cold, and the cold seems to never go away. A parent will think that every time the child will be having running nose, the child will be having a cough that is existing for about 10 to 12 days. The child will become a little better. They will send to school, and again there will be an episode of a respiratory infection and again a wheeze. So this is the commonest point we are seeing, a recurrent respiratory infection in children less than 5 years. So COVID-19, what happened? It broke this cycle. Children were not going to school. Okay. So there were not many children who came with asthma episodes during COVID-19 in the younger age group. But on the other hand, what happened is, what is the commonest reason when we getting the cold that is asthma in older children, is due to indoor allergens, that is what are present indoor. it is one thing, main important thing is your dust mite. This is a very small insect that is even less than the COVID. This is very less, and it is present in the carpets and in the fur toys, wherever the children in the bed, mainly bed covers. That is why we talk about covering of the beds for allergenic materials and everything. So this triggered asthma in children who were confined to homes more. Cockroaches and pets. So they were more in contact. So this was one of the other flip side of it. By far, the COVID-19 pandemic showed us that clearly the allergens had been there. So we had one group of children who had reduced exacerbation when it was due to a viral infection, but we had, on the other hand, an increase of asthma in a little older children when it was due to sensitization to the indoor allergen. So it was multifactorial. You cannot generalize things. And the second factor we learned is nebulizations could not be used. We could not use nebulization because nebulization was a potent mediator of spreading the thing. And we pediatricians were more exposed to it because children coughed more. And if they were COVID positive, it was also coughing only they came up with. And we were exposed more to the COVID-19. And the other factor that came up is nebulizers were completely there. So there was a new, we had to teach the parents to give the spaces at home itself. Unfortunately, this was one of the other flip side is people started giving nebulizers in the home a lot. So this practice is continuing, whereas the guidelines have clearly changed that no more nebulizations are used in the home. And we should be giving only spaces. And even in the hospital, when the child is only acutely ill, we have to use nebulizers, and that too with oxygen. But unfortunately, the management, now the parents have taken it in their hand. They think they have seen that when they go, they are giving only nebulizers. So they've taught giving it in the house, but there is no more required one that increases the oxygen, decreases the oxygen saturation in a very bad way. And the third thing is we are moving on to spaces that is much safer for home management of asthma. So you give the nebulizer, you give the spacers with the bronchodilators, child is not improving, you ask them to come home. But I would say overall there has been an increased awareness about after COVID. So people are coming more and asking questions. In that way is better. They also know about the saturations, and when we explain to them the SpO2 and what nebulizer does, they also understand better. So
Yes.
it's a learning, but we cannot generalize too. But we don't want that worse learning for any of us.
Yes, very bad, I would say.
Yeah.
Now, what are the risks associated with using high doses of steroid to overcome resistance in children, and how do you balance the potential benefits with these risks?
Okay. So the thing is that steroids are two things. One is how do you take them? Okay. Steroid is a double-edged weapon. It's a wonderful medicine in the right hand for the right disease, and when given right. If you're giving the same steroids in the wrong hand in a very high dosage, in a parent, in a person who's not aware of the same, it leads to serious damages. So what are the damages it can come? So one is in the adult, this is for everybody. You put on weight, your hormones are disturbed, your obesity comes in, your immunity is basically comes down low, you are more prone for infections, and if suddenly the body loses its ability to fight against infection also, and what happens is when you suddenly stop the steroid, you are more prone for recurrent infections, and your body does not take up the stress. So this leads to create a huge problem in case of an adult. But the same thing comes to the children also. All the problems exist. And one more thing is child is a growing. It's an adult. He's a growing child, right? So the bones lose the calcium. So they becomes a thin bones. The growth is affected. And as I said, that hypothalamic pituitary axis, which is very, very important for hormonal regulation, is gone. So this leads to a lot of hormonal imbalance in a child. So this is what basically happens when you take a high dose of steroids. Okay. Having said that, what's the alternative here is this all comes when there's an oral steroid, or when the child is taking a tablet or a syrup formulation of steroid. So that is why we don't want parents or any of the healthcare providers to give steroids, and the oral tablets are restricted to an acute stage. That is when the child is having a severe difficulty in breathing and is in a life-threatening condition and admitted to the hospital with severe difficulty in breathing. We always prefer inhaled steroids. Inhaled steroids, the dosage what we give for children is only in the form of 200 to 400 micrograms. Whereas the dosage for oral is 1 milligram per kg. So in a 15 kg child, you would be almost going up to 15 milligram. Whereas in an inhaled steroids, I give an inhaled steroid, the maximum permissible dosage for a child is even up to 1200 microgram. till 800 micro. When it's going above 800 microgram only, we call it as a high dose steroids. And we have seen that then again there is a problem with hypothalamic pituitary axis. But in my experience of as a pediatrician allergy specialist, whenever the technique is being corrected, when the parents know how to give, the dosage of steroids I have used, including intranasal steroid for allergic rhinitis, does not cross more than 300 to 400 in a day. So you take 400 microgram for 10 days also, it's just about 0.4 milligram. And imagine you're giving steroids, oral steroid in a day, you go up to 15 milligram. So if it is being repeated 3 times in a month, then it goes up to 45 milligram, and there's a cumulative problem. Whereas when you are on inhaled steroids, there is a very good thing that even the inhalers control the inflammation, which I already discussed. So the thing now is start on inhaled steroids much earlier and keep giving inhaled steroids wherever it is required. That's why we want them to give the spacers and use inhaled steroids in the spacers. Treatment is the same, but it's how you are giving it matters.
Yeah, it also have everlasting effect on children considering their age.
Yes, definitely.
Yeah.
So don't worry about steroid. If your doctor is going to give you, it's going to know the dosage. But if you want to avoid the side effects, the best thing is if your child has been advised about taking inhaled steroids, that's the best thing you can do about the same.
Now, how can physical activity such as exercise and environmental factors like exposure to cold air affect asthma diagnosis and management?
So first thing I would tell you is the environment, the heat is, all are thinking that cold air is having a effect. I'm telling you, cold air has got an irritant effect. Okay, so when I'm inflamed, when I go out, the cold air strikes me, so I start coughing and the wheezing develops. So that's the only thing. The cold air is an irritant, whereas the present heat wave, you would have seen a lot of literatures on that. The air pollution, the heat has directly contributed to increase in the number of asthma attacks in children, because the heat pollution, the changes in the climatic condition and environmental factors have also led on to increase in the dust mite, there is a change in the number of pollens we are having in the atmosphere. And one more thing, the smoke and the carbon dioxide exposure, which I have not spoken about still, is the major culprit in increase in the respiratory disorders in children. And it has been directly linked to the number of deaths we are seeing in respiratory disorders. So heat, smoke pollution, environmental pollution, which we are really having. So we did have asthma before. It's a known disease. But why is the increase here? It's a change in the environmental conditions. And heat indirectly is affecting the mortality and morbidity of respiratory disorders and asthma in a major way. And asked about the first part of your question was it was a yoga and swimming. Generally, in a well-controlled asthmatics, we encourage them to do the exercises, because exercise is a good factor which improves your respiratory muscles also, even including swimming. And there are also studies that have said that it's very good for the thing, unless it's an irritant that is coming up. One more thing is yoga, pranayama, and a good running exercise are very, very good for children to have a better control. And there is one factor of asthma that's called as an exercise-induced asthma, where the exercise itself induces asthma because it's due to a lot of pathological mechanism. It's very difficult to explain here. So Olympic players, 25% of them do have asthma, which has been triggered by exercises. But that is not equivalent to the asthma we are talking here. It's not a pathological asthma. So they are allowed to take inhaled steroids. That's the only steroid that is allowed in an Olympics games. So asthma need not be a factor that prevents your child to do any sort of an exercise or an activity. So in a mild asthma, the parents want to avoid drugs, it's absolutely fine. Take it only when it is required. Encourage your child to do pranayama, encourage your child to do exercises. Definitely it gives a very good control. And exercise is always an anti-inflammatory. Good exercises, good sleep, avoidance of all this, all the junk foods, and a peaceful sleep for the child itself is a very good home remedy for asthma, I would say.
Yes, that is an excellent advice. Now finally, let's discuss advancement in the field. What are the latest guidelines for the management of pediatric asthma and how they evolved in recent years?
Yeah. So initially, whenever we had asthma, we were looking at only controlling the symptoms. Okay. So this is called as an asthma control medication. So, but as I told you, every time a child has an asthma episode, there is some amount of basic inflammation that is going on. So we are looking at controlling the inflammation. We do not want any of the inflammation having a lasting effect on the child. And again, another factor is the comorbid feature, as I tell you. When I'm giving inhaled steroid, I will be able to control only the airway. So what happens to the allergic conjunctivitis? What happened to the allergic rhinitis? It's also progressive. So whenever we see a disease which is progressive, just controlling the disease is not okay. So we are looking at factors that is going to modify the disease completely. And now we are there is a lot of advancements in immunology and immunotherapy. So we have understood the basic immunological concepts of asthma, and we have brought in allergen immunotherapy for children. And now it was advised above 6 years and 7 years, and there are variations in asthma in allergen immunotherapy antigens that even children have started we have started considering it. And my personal take is, whenever there is a progressive medication, progressive allergy, and that too involving too many symptoms, and this I would definitely go in for this. But this is not the case for a child who is having a very severe asthma. In a severe asthma, you would have heard the biologicals have come in. So when you know about what is a biological, we would be thinking, tocilizumab, which was used for COVID. Everybody knew about that medicine. It was a very costly medicine, and government had to put in a lot of regulation. So similarly for asthma, we have gotten a lot of biologicals. So when you know and one biological which has been in vogue in adults and in adolescent ages, now omalizumab, which has really come up, just changed the way we are managing it. So omalizumab, and there are a lot of biologicals. Dupilumab has now come for food-induced allergies, atopic dermatitis. Lot of research are going on in the world with regard to biologicals. So, but we have to be very, very careful. As I told you, 90% of my children do very well when we have a good diagnosis, when it is understood by the parents, when there is a lifestyle modification. Obesity is one of the comorbid features I forgot to tell you about. So children become obese because they don't want to have the activity. And then you have a good amount of inhaled steroids. And when we make this world a better place for everybody to stay, asthma would definitely come down. More plants will definitely, of course, pollens will be there. But that is one more thing. Heat will come down, dust allergy will come down. So this itself will be getting. I'm talking about immunotherapy for a very small sector when there's a progressive. Allergen immunotherapy is much more wider. People can be used when it is a progressive disease. But biologicals is for less than 1% of the children who are in the top of the pyramid whose disease have not been controlled.
Thank you for sharing that, Doctor. Thank you, Dr. Narmada. It was great discussing these important aspects of asthma management in children. It was a pleasure having you again on the podcast and gaining your expertise.
Thank you. I'm also very happy to meet you all through this podcast and also have this excellent interaction. And thank you, MedSynapse, for giving me the opportunity to share my thoughts and expertise for the same.
Thank you. And to our listeners, thank you for tuning into today's episode. And to our esteemed healthcare professional, if you are eager to delve deeper into medical topics or have questions, don't hesitate to join us on MedSynapse platform. MedSynapse platform is not just a resource, it's a dynamic space where you can connect with your medical peers, participate in meaningful discussions, and contribute to the ongoing evolution of healthcare. Stay safe, stay healthy, and until next time, take care.